Hello, everyone, and welcome to the live Q&A Vitiligo Doctor panel. My name is Amit Pandya, and I'm very happy to be here with my colleagues, um, uh, physicians who are going to speak to you today about vitiligo. This is a chance for you to ask questions and for us to give you some answers about the pathogenesis, what causes vitiligo, what treatments are available, and any other questions you might have. So please feel free to enter your questions so that we can discuss them. Well, let me introduce myself first. I am a dermatologist practicing at the Palo Alto Medical Foundation in Mountain View, California. And I have a pigmentary disease clinic. And prior to that, I was a professor at UT Southwestern Medical Center in Dallas for 30 years. Now I'd like to introduce my colleagues here today. So first and foremost, I'd like to introduce Dr. Pearl Grimes. We are indeed fortunate to have Dr. Grimes, who's a friend of mine for many, many years. Dr. Grimes is the head of the Vitiligo and Pigmentation Institute of Southern California. She's also clinical professor of dermatology at UCLA in Los Angeles. Dr. Grimes has decades of experience in vitiligo. Indeed, she taught me about what vitiligo and pigmentary diseases are all about. She has an numerous long list of publications. And if you've never heard Dr. Grimes speak, then you're in for a treat. She has a great down-to-earth way of explaining complex information that I think you will enjoy. And she has this one-of-a-kind, graceful, genteel, Southern charm way of explaining it that I think we all just love. So I'm welcome Dr. Grimes to this program. Next, I would like to introduce Dr. John Harris. Dr. Harris is Associate Professor of Dermatology at the University of Massachusetts. And I would say, I'm a limb, I think most people agree with me, he is arguably the top researcher in the basic science of vitiligo in the world. All right, I said it and I believe it. He knows he studies what causes vitiligo and new ideas on how to fix it. I mean, things I never even thought of. He takes these mice and he gives them vitiligo, and then he does something, and then all of a sudden the vitiligo gets better, and then he says, I think this causes vitiligo. And I say, oh, I never thought of that. So it's great to have Dr. Harris here. He has this no-nonsense, very straightforward way of kind of a do not beat around New England way of explaining, these complex topics. And I think you're going to enjoy it. And so finally, we have Dr. Seemal Desai, who comes from Texas. He is the head of innovative dermatology in Plano, Texas. He is clinical assistant professor of dermatology at UT Southwestern Medical Center in Dallas. And he brings the view, for one, of the private practicing dermatologist, which is 90% of dermatologists in America who see the majority of vitiligo patients. And he's also a leader in multiple organizations. One thing that Dr. Desai has done is he's gone to Congress and he's knocked on the door of legislators, and he has been an advocate for vitiligo to our leaders to try to get more research and more information out about vitiligo. And so he brings that practicing dermatologist point of view, and really has an excellent speaking style, and you'll be able to understand vitiligo through him and his approach. So I want to welcome all three of my co-faculty to this panel, and then we're going to get started with the Q&A session. All right. So first of all, what I'd like to do is do a poll question, and this will be a chance for you to answer the poll. And the poll is up there. And what do you think causes vitiligo? Please click on one of those. All right, and here are our answers. What do you think causes vitiligo? It looks like the answer that's highest is all of the above: genetics, environmental stressors and triggers, diet and nutrition, and then there was a small group that said other. So, all right, so let's go to our panel. Let me start out, the ladies first, with Dr. Grimes. Dr. Grimes, what do you think of these answers, and what do you think are the causes of vitiligo?
Well, I think that if you look at all of our scientific data, vitiligo is truly a complex disease. And we think there is a complex interplay between genetics. Genetics clearly plays a role in that 35% of patients with vitiligo will have other family members. There's been some exciting work in the last 10 years on the genetics of vitiligo. We think that most of the genes that are involved are what we call immune susceptibility genes in the overwhelming majority of patients. We also know that oxidative stress, the melanocyte tends to handle oxidative stress poorly compared to normal melanocytes. And John has really been key in really being able to define the pathway regarding autoimmunity, the precise autoimmune mechanism for the destruction of melanocytes. So to summarize that, I call it the trifecta. And the trifecta is genetics, oxidative stress, and that final autoimmune mediated destruction of melanocytes. Going back to the question, I'm often asked whether or not diet and nutrition play a role in vitiligo, and we really don't have that data. However, I'll qualify it and state that when it comes to autoimmune diseases, I think that I always stress with my patients the importance of a healthy diet and healthy nutrition for overall in dealing with autoimmune diseases.
Okay, well, thank you. And that's interesting about how you brought all those different factors together. You did mention Dr. Harris, so I'm going to go to him. John, what do you think in terms of this question? What causes vitiligo? Genetics, environmental stressors or triggers, diet, nutrition, or all of the above, or other?
Thanks, Pearl. So the first paper that we published really kind of that began the process, I think, of JAK inhibitors was rediscovering a pathway that you described in the 80s when you were looking at gene expression in vitiligo, interferon gamma. So nothing's ever new. And we were reading your old paper, I think, when we were preparing our paper as well, and saying, wow, this has been known for a long time. So Pearl's right, so genetics underlies pretty much everything, right? The genes that you inherit influence whatever happens. Autoimmunity is an important part. We think that the reason people get vitiligo is because we've got an immune system that protects us against cancers like melanoma. So when you have vitiligo, you've got a lower risk of getting certain cancers, including melanoma. And if your immune system's just really good at that, then you're at risk of getting vitiligo. So everything's kind of a balance in our bodies, and when things get a little bit out of balance, then that's where you get disease, including vitiligo and autoimmunity. And we do think that melanocytes are a little sick to start with, and that's what triggers the whole process. And there's probably a ton that we still don't know. That's what's fun about studying things, and there's always more to learn. And so I agree with Pearl. We don't really have any evidence right now that diet and nutrition play a big role yet, but there's still a lot to learn, and a healthy diet's really important.
All right, I'm going to turn to Dr. Desai, and Seema, I'd like you to answer that question, but specifically since you and I are both Indian, and we see a lot of Indian patients, the question that a lot of people from Asia ask, because they've been told this by their relatives and others, is that diet is super important for vitiligo, and that if you don't avoid certain things, your vitiligo is not going to get better. So what do you think about that, Seema?
Thanks very much, Amit, and thank you for hosting this panel, and to be here with my colleagues is really a privilege, and to share this with the audience. So special thanks to GVF and to MyVitiligo teams for putting this fantastic event together. I completely agree with you. In fact, everyone can see that I'm still in my scrubs because I was rushing home from seeing patients today, and my last two patients of the day, believe it or not, were new diagnosis vitiligo patients, both completely separate patients of Indian origin, one actually of South Indian origin, one of North Indian origin, both with autoimmune disease, both with a history of autoimmune thyroid disease specifically. And Dr. Harris just alluded to autoimmunity and making sure that our vitiligo patients are aware that as a medical condition, there are other autoimmune things that we as the dermatologists need to screen these patients for: thyroid disease, iron deficiency, anemia, and others. But both of those patients specifically were very concerned about diet. And that's because there is a lot of cultural and social history, for lack of a better description, behind the concept of diet affecting vitiligo. But we don't have any data on that. And so what I tell my patients is there is not one food to avoid. I actually get the question specifically, is there a food I should avoid? I'm sure all four of us have gotten that specific question. Not even just diet, but specifically, doctor, is there a food I should avoid eating? And some people say, oh, well, I've heard that this food causes more body heat to build up. Is that going to cause me to have more inflammation and cause this to get worse? And the answer is we just don't have good data. So I encourage a healthy diet, just like all of you, my colleagues, experts. I encourage screening patients for other autoimmune diseases. And for anyone who's watching who has vitiligo, but may not have been screened for other autoimmune diseases, make sure you talk to your board certified dermatologist about that. And also encourage healthy lifestyle habits.
Okay, great. So what I'm here, oh, go ahead, Pearl.
I can't resist. You know, I gave a lecture a number of years ago, and we talked about pears and blueberries having high contents of hydroquinone. And then this circulated on the internet. You can't have a pear and you can't have blueberries. And in my entire career, I've never seen a case of pear or blueberry induced vitiligo. So I just want to make that clear. You can have a pear and you can have blueberries, okay? And blueberries in particular are very high in antioxidants, which is important for your overall health.
Yeah, I'm glad you mentioned that, Pearl. And one thing that a lot of patients really need to understand is the whole concept of evidence-based medicine. If one person avoids blueberries and pears and their vitiligo gets better, and a second person avoids blueberries and pears and their vitiligo gets better, that doesn't mean every vitiligo patient in the world should start avoiding blueberries and pears. Let me try to explain it in a way that maybe everyone can understand. If you flip a coin, most of the time it's going to be heads 5 times and tails 5 times, right? But sometimes it's going to be heads 10 times and tails 0 times. Well, suppose those first 10 people who avoided blueberries and pears, their vitiligo got better. Are you going to conclude that that's definitive evidence that from now on, everybody should avoid blueberries and pears? That's not the way we do this in science, and it's for your benefit. It's for your benefit that we actually try to prove ourselves wrong. We actually have controls, we have placebos, we go about trying to prove ourselves wrong because we want to make sure that the treatment you're getting is absolutely positively been proven to work. So I tell my patients, have 5 servings of fruits and vegetables every day. And by the way, 1 serving is half an apple, not a whole apple. So you don't have to worry that you have to eat 5 apples a day. But 5 servings of fruits and vegetables a day and a handful of nuts. That gives you your vitamin C, vitamin E, vitamin A. It gives you antioxidants. And that's, you don't have to avoid gluten. You don't have to avoid citrus fruits. You don't have to avoid dairy products and wheat and combining, for example, meats with dairy products, like they say in Asia. You don't have to do that. That has not been scientifically proven, especially not in a child where you're torturing the poor child by removing pizza and removing things to that poor child because you feel like that's causing the vitiligo. So I think just to summarize what everyone said, 30% of patients with vitiligo have relatives, but remember 70% do not. That's because genes are important, but it's not the only cause. The second thing is environmental triggers. Your identical twin can have vitiligo, but you only have a 23% chance of getting it. That means there's something in the environment that's causing it, and that's what Dr. Harris and all of us are trying to figure out, what is it in the environment. And finally, there may be something in diet and nutrition that can help stop the triggers of vitiligo. All right, well, there is one follow-up question to that question that I was wondering if my colleagues would like to answer. And that is, I think that hormonal disorders is important to cause vitiligo. Is that true? And I assume a hormonal disorder would mean excessive estrogen or excessive androgen, where a woman might not have periods or irregular periods, or it could be like lack of testosterone from a man, or any type of hormonal disorder. Do any of my colleagues want to mention? Do you think hormonal disorder is the cause of vitiligo?
I'll go first. Having been in the trenches with vitiligo patients for decades, I just have not seen a relationship between hormonal disorders from the perspective of androgens and estrogens playing a major role in vitiligo. We know that during pregnancy, some patients will get worse, but then I've also seen patients get better. Is it in the majority of women who get pregnant? Absolutely not. So I have not seen a correlation between that type of those types of hormonal issues and the pathogenesis, initiation, or in general flaring of vitiligo. From an endocrinopathy perspective, you certainly can throw thyroid disease in that bucket. And if we look at vitiligo in general, we know we have the strongest association in comorbidities or associated illnesses. There is a 15% or higher likelihood that if you get vitiligo, at some point you may develop a thyroid disease. The most common thyroid disease is Hashimoto's thyroiditis, but we also see Graves' disease or hyperthyroidism as well. So those have been my historical experiences.
And John and Seemal, do you want to make any comments about the hormonal issue? And then secondly, can you answer the question, what is the likelihood of passing vitiligo on to your children? I'm going to call on Seemal first this time.
I saw you unmute, Seemal. You were ready to go.
Sure, John, go ahead.
Okay, go ahead.
So just to comment, that I've seen the pregnancy thing too, and I've always wondered if there's something there, but we definitely don't see any spike in vitiligo around puberty, when hormones are changing. We don't see a decrease after menopause. So there really isn't any clear association with those hormones anyway, sex hormones. Although the pregnancy thing I think is really interesting. I've seen it too. And I think I see more getting worse during pregnancy than getting better. But as Pearl said, that it's not the majority of people. So it's not something to worry about. But if there's an association, we just don't know.
And John, what are the chances of passing it on to your children?
There was actually a fascinating study just published, I think last week or a couple of weeks ago. We're writing a commentary on it. That's an update. We've always said that it's about 5% or 6%. So the risk of getting vitiligo if you don't have a parent with it is 1%, 1 in 100. If you do have a parent, the risk is about 6 in 100. So it's an increased risk. So genetics are important, but it's still not a very big risk. I always tell people, that there's a 94% chance that that your children aren't going to get vitiligo. And so it's relatively low, although it's increased. There are some really new, interesting findings from the new study from Korea where they looked at a large number of people. And it also says 5 or 6% if your parents have it. So that confirms that. There's also a slightly increased risk if your spouse has it. So that's kind of interesting. If your spouse has vitiligo, your risk is 1.8%, which is a little bit higher than the 1%. We don't know if that's because people with vitiligo are finding other people with vitiligo to marry, or if it's there's some kind of environmental exposure. Dr. Grimes actually described a married couple. We wrote that in our commentary, Pearl. But a married couple that got it from using monobenzone cream, right? The depigmenting.
I've actually, John, had a number of married couples who developed vitiligo. We always struggle to explain it. And when we published our paper on cytomegalovirus as a possible trigger for vitiligo many years ago, we talked about consanguinity. We talked about couples having vitiligo in that paper. But as I said, it's a phenomenon that I've seen over the years. It's not new.
Amit, if I could just add the importance of letting patients know and reassuring many patients, especially when we have parents who come in who are worried about passing it along to their children. I see that a lot. And I think it's really our job to try to reassure those families and make sure they leave our practices feeling uplifted instead of in fear, because I see so many of these patients coming in who are petrified and mortified. And Amit knows this, but in many cultures, this is a stigma, even when patients are dating, when they're getting married, when they're going through the process of fertility and family planning. And so I think the important thing to mention here is that the risk of directly passing it on to a child is really quite low. One thing that I will say, which I do tell all of my patients, is I don't want you to stress about what if you were to give it to your child, because that risk is quite low. And what I tell my patients is the more you stress and the more you increase your anxiety and continuous stress about your own vitiligo may get worse. We know that stress plays a role in inflammation and in the body of the patient itself. And so I try to flip the dialogue. And the other thing I'll comment on is we've talked about thyroid, we've talked about other autoimmunity, and we've talked about hormones. But remember, what you want to tell your patients, and what I try to tell my patients, is it doesn't matter that no one in your family had vitiligo, but did someone in your family have diabetes? Did your grandfather have thyroid issues? Did someone have rheumatoid arthritis? And so look for those other family history of autoimmune genetic conditions, because sometimes that may help the patient to better understand why they got it. I get that question a lot. Why did I get it and no one else in my family got it? And so it's not about why you got it, but let's look at the entire family and delve into the history a little bit. And maybe there are some telltale clues that will help at least give you a little bit of closure to that chapter. I'm sure all of you have gotten that question as well.
I agree with you, Samal, 100%. And the way I deal with it is, going back to the genetics and Spritz's work and immune susceptibility genes. And my explanation is one person may get vitiligo, someone else may get thyroid disease, someone else may get rheumatoid arthritis, and someone else may get all three. So there's clearly that immunogenetic predisposition playing out here. As far as parents being concerned that they're going to pass it on to vitiligo, I think our job as caregivers and clinicians is to, what I'm going to define it as peeling parents off the wall. They come in with so much stress and so much concern. And my approach is, look, you're not going to change this. So it's wasted energy. It's stress that is going to impact you. I agree with you long term. So again, we work to put it all in perspective, to allay that enormous anxiety on the part of the parents that they're going to pass this on to the kids. And I think we really do have to work to stress it's a low likelihood that your kids are going to get it. I mean, it's possible, but we have to stress it is a low likelihood. If it happens, we'll get it early. And then my other point is, if you look at kids, if you look at adults, guess what? Kids do so well.
Thank you. Thank you, all three. Well, we need to move on to treatment. There's a question about cure and such. And as you can see, everybody, there is no lack of conversation between us because all four of us are friends. And part of it has to do with the fact that we karaoke. And my philosophy is doctors who karaoke together stay together. So that's why one of the reasons you're hearing all this conversation. But I just wanted to summarize a couple of things before we move on. If you're pregnant, if you have vitiligo, you should not hesitate to have a child. What we talked about today about pregnancy doesn't mean that you will get worse during pregnancy. Some people get better, some people get worse, but phototherapy can be used during pregnancy. And so please don't think that you should not get pregnant because your vitiligo will get worse. Sometimes it can get worse after you deliver, and we can be prepared for that. Dermatologists can be ready to treat you for that. The second thing I want to say is if you do have a child who has vitiligo and you have vitiligo yourself, what Dr. is talking about in terms of the guilt, yes, I'm sure that there is some degree of guilt that, I have vitiligo and now look, my child has vitiligo. But again, like Dr. Grimes says, it is what it is. You cannot change that. But what you can do is try not to stress about it yourself so that your child doesn't stress and make the vitiligo worse. Not only that, think of the advantage you have. You have lived with vitiligo. You know what it looks like. You know what that first spot looks like, and you probably know how to treat it. That child is going to be at a great advantage in terms of treatment and dealing with vitiligo because they have a parent who knows all about it. And so the final thing I want to tell you is something that we talked about a little bit, but I want to make sure everyone understands this. Vitiligo is caused by these cells called T cells that are in your skin, and they actually climb up into your epidermis, they find your melanocytes, and they kill them using interferon gamma and other chemicals. And if you biopsied your skin right now, you would see hundreds of these abnormal cells killing your melanocytes, and they're not supposed to be there. Okay, that is the cause of vitiligo, and that is the focus of our treatment. It's not blueberries, it's not pears, it's those cells that are actually in there killing those melanocytes. I want to make sure everyone understands that. All right, we're going to go on to the next question, and that is a question that was sent in by a lot of people. And so I'd like to ask the panel, is there a cure? And if not, when is a cure coming? And what new treatments are out or coming soon? So who would like to start with that question? Is there a cure? When is a cure coming? And what new treatments are out or coming soon?
Well, Amit, I can briefly start if that's okay with you. What I tell my patients is there is not a cure. And I like to be very optimistic, but very clear to my patients from the first visit, because I want my patient to have the same expectations and be on the same journey as me. This is a team-based approach to helping our vitiligo patients. However, I am very hopeful and I'm very optimistic that we will find a cure. And I want my patients to be equally optimistic. When I was a resident learning about vitiligo and treating patients with vitiligo, half of the things that we do now in our practices weren't even available then. Some of the new therapies, especially the Janus kinase inhibitors and many of the antibody related work that has come out of John's amazing research, there was no idea we would even have that. Systemic steroids and how we now do that even more elegantly than before, using steroids where you can give them just 2 days a week to help slow down the spread of the disease. We weren't doing that a few years ago. We weren't recommending antioxidants all the time. We weren't doing newer ways of phototherapy. So the journey is just in its really exciting phase right now. And I really think the best is yet to come. And I think that's an important message I know all four of us share with our patients. But where there is no cure now, but that does not mean we won't have one hopefully soon.
Thank you. Dr. Grimes, Dr. Harris?
John, you want to go first?
Sure. So that's right. We don't have a cure for vitiligo. We don't have a cure for most things though, right? So if you have hypertension, if you have heart disease, if you have any number of things, we can't cure those, but we can treat them. And it's the same for vitiligo. We've got great treatments that will help you. Some of the treatments that we use, phototherapy, light therapy, they've already been mentioned in the comments. The royal we, I guess, we've been using them since the Iron Age. In India and Egypt, 3,500 years ago, people were using the sunlight plus a black seed to chew on. And that combination really helped vitiligo at the time, and we still use a version of that today. And it's just a matter of knowing that the treatments do help. Somebody asked whether the white spots will come back eventually, and that's the case. So if you take a treatment for vitiligo and you get better, and then you stop the treatment, eventually we typically see the white spots come back. It might take a year or 2 years or more, but then you can start the treatment again and get better again. So that's the good news. The JAK inhibitors that people are excited about, they seem to work even better. They still don't appear to be a cure though. So that was the hope. And when you stop the JAK inhibitor, maybe it'll never come back. And that's not what we're seeing. So just like everything else, even though they work better, they're not the cure either. Curing something's really hard. I wrote a blog about this because people kept bringing it up. So I wrote a blog about how hard it is to cure something. So read about that because it's too long to talk about now. But the good news is we do have excellent treatments, and we have even better treatments that are coming. And the JAK inhibitors are one of those, and we think that there are plenty more to be done. Although I won't give up, we're always trying to find the cure. I think that we might get there if we work hard enough and give us enough time.
John, what is the name of your blog, just for our listeners?
It's if you just Google Harris vitiligo, it'll come up. That's usually what people. It's called
Speaking of vitiligo.
Yeah, speaking of vitiligo. ...
Quickie comment to me, and I'm not going to talk about JAK inhibitors because John and Samal already summarized that very beautifully. But you know, I guess having been in the trenches for so long with patients, every single day, it's still the emotion. We eventually get a cure? Absolutely. And I think one day we may get there. But as John alluded to, it's very difficult. But the point that I would like to make is this. If you take the existing tools in our toolbox, the standard tools that we have and the emerging tools, and I'm going to frame that and also make the point that this is really a very exciting time for vitiligo research, because I think we've made so many advances that really allow us to be much more effective in how we care for our patients. But if you take standard and emerging, those that are available, I think we really can move forward and at enhancing our outcomes of repigmentation, stabilization, and long-term maintenance for patients.
Just one more comment too about cure. I think we do actually have a cure for vitiligo in a very small number of people. And that's those with segmental vitiligo. Somebody asked about the procedure, the transplant procedure. We call it melanocyte keratinocyte transplant procedure, MKTP. For those patients who have segmental vitiligo, it's only on one side of the body. It's been stable. It hasn't changed in a really long time. And you get that transplant procedure. Generally, when patients do well with that it doesn't seem to come back. So I guess we could call that a cure. That's probably the only type of vitiligo that we can cure.
Right. And so I just want to follow up on that for the listeners. 85% of vitiligo is generalized vitiligo or non-segmental vitiligo. Only 15% is segmental vitiligo. So the MKTP and other vitiligo transplant procedures do very well in segmental vitiligo, but we're only talking about 15% of vitiligo patients. I just want to make a comment on the word cure. Patients ask me, what are you going to do for my vitiligo? And I said, we're going to try to get rid of those cells in your skin and try to bring the melanocytes back. And they go, okay, are those cells going to come back? And I say, I'm not sure. They could. And they say, why don't you get rid of the cells? Where are those cells? Where are they coming from? I said, those cells are actually coming from your lymphatic system, from your immune system. Well, don't you have a way of getting rid of those cells permanently and for the rest of my life? And I don't. And that will be the ultimate cure when those cells can be removed. But there's 62 autoimmune diseases. We don't have a cure for lupus. We don't have a cure for rheumatoid arthritis. We don't have a cure for a lot of diseases in which the immune system is making cells that cause it to continue. There's not a way you can remove those cells without damaging your normal immune system. That's the problem. So maybe one day, like Dr. Grimes says, there will be a way when someone first starts getting vitiligo, or perhaps as a parent with vitiligo or family history of vitiligo, that we can prevent those cells from being made in the first place. difficult to get rid of those cells after they're being made. But those cells are still being made in these patients. So I don't know if you have a comment on that, Dr. Harris.
Sure. Yeah, because I keep seeing the IL-15 pop up on under the chat, and people follow me on Twitter, and I get that question every day. Well, what about IL-15? So I should probably comment on it. I've been quiet for a while, and everybody assumes that's because it's not working and things are going poorly, and that's not true at all. So a lot of people know that I started a company to target IL-15, to develop a new drug to target IL-15 signaling to treat. I try not to talk about it too much because it's an obvious conflict of interest, right? That's my favorite thing right now. I do believe in it very much, and we think that that's probably the way to remove these memory cells that are forming in the skin causing your vitiligo. I wrote a bunch of blogs on it, so you can read more about it there. It turns out that the reason your vitiligo comes back is those immune cells that go into your skin and kill your melanocytes actually form memory, and they stay there forever. The reason is because those same cells are what protect you from viruses too. So if you get a virus, you fight off the virus, you leave some memory cells behind in case that virus ever comes back to protect you. So that's what you want. The same thing happens in vitiligo. So those cells go in, they clear the virus, or they kill the melanocytes, and they stay there forever. So when the melanocytes try to come back and your skin gets better, as soon as you stop your treatment, they wake back up and they reinitiate the whole process over again. So what we found, and Amit was on this paper with us too, is that IL-15 is required for those cells to stay there. And if you block IL-15, the cells go away. And then the skin gets better, and we think that it stays better. So we're not calling it a cure. Maybe it will be. That'd be fantastic. I think it's a big ask. It's the closest idea that we have to a cure. We were preparing for clinical trials about a year ago, and it was done through the NIH and grant funding and to test an antibody. Because I started the company, I had this conflict of interest and I couldn't continue that. But that trial is still going to happen, I believe, very, very soon. It should be this year, this calendar year, under another doctor. So keep an eye out for it. Meantime, my company's doing great. We're making a lot of progress, and we're still really excited about it. But things don't go as quickly, I can tell, as people would like, because I get that question literally every day. And I try to answer it, almost every day. It's just, you got to be patient. It takes time. We got to make sure it's safe as well as effective. And so that's a lot of work to do.
Well, you brought clinical trials, and that's our second poll question. And so this will be a good chance for us to talk about clinical trials. So could you please put up the second poll question? Okay, we have our answers. Wow, 55% would consider participating in a trial. 15% would say no, 6% already have, and 25% are on the fence. All right, well, let's go to our panel, and let me ask what you think of these answers, and what do you think? Do you think your patients should participate in clinical trials? And if so, what trials are?
So Amit, I'll quickly mention, and John is very modest about his IL-15 work, and he doesn't talk about it a lot, but my opinion is he should talk about it as much as he wants because it's so exciting and he's done great work on it. But that he mentioned trials, and I will tell you, in my practice, we do lots of clinical trials. We currently have 2 vitiligo studies that are actively enrolling, and we have patients in another 2 that have stopped enrolling. Specifically with the JAK inhibitor drugs. And if you don't mind, I saw several questions in the chat, since we already talked about JAK inhibitors. Several people asked, how do they work and what are they? And what I do in my clinical trials when we're discussing trials with patients is try to make it sound very simple. So what I tell patients is that a JAK inhibitor is a drug that's going to bind to two proteins on the outside of a cell. And if you bind a protein on a JAK receptor, so in this receptor is supposed to sit a signal, but if you block that signal, then the protein can't send a further signal to the next base. So it's like if you're having a pitcher and they strike out already at home plate, you can't make it to first base. And that's the goal of the JAK inhibitor. You're trying to block the signal on the outside of the cell, so that way that protein cannot send any more signals out and then subsequently cause the process of inflammation. So in IL-15, as John mentioned, all of these cytokines or proteins or signals, whatever way you want to call them, they all work via certain steps. And the JAK just happens to be one of those steps. So JAK inhibitors in simplistic terms means you have a medicine that blocks one of the receptors or signals in inflammation, we think, which causes all of those cells to attack the melanocytes. And so that's how I explain the JAK inhibitors to my patients that I'm prescribing it for, which, by the way, is still FDA off-label, and I counsel all of my patients on that, but also those who I'm putting in clinical trials, because I think there is some promise in clinical trials. And I do encourage my patients to enroll in clinical trials if they are willing to be involved in a long-term study for vitiligo. Not all of my patients want to do it, to be honest. Some patients want to go with the therapies that we currently have and we know. And some patients are willing to go into the trial because they've exhausted all of their other therapies. And I see many patients. In fact, when Dr. Pandya and I worked together here in Dallas, we saw many of the same patients, and I now see many of his patients here, and we all see each other's patients. I see some of Pearl's patients from LA and vice versa. Patients are very motivated, and I tell my vitiligo patients that this group is some of the most motivated and committed individuals of all of our dermatologic patients, in my opinion. So I do think clinical trials play a role and are very helpful in settings.
Dr. Grimes, thank you, Dr. Desai. Dr. Grimes, how do you feel about clinical trials, and how do you recommend clinical trials to your patients, and which ones do you know that are active right now?
Well, I run a clinical trials institute. So we've been involved in clinical research studies for vitiligo for many years. Currently, most of our clinical trials for vitiligo are either investigating an oral JAK inhibitor or a topical JAK inhibitor. So I think that these drugs, once they are approved, will make major shifts in how we approach vitiligo. So obviously I am an advocate. I think the key for me in offering a clinical trial to a patient, we want to be certain that that patient is motivated to stay in a study. So one of the things, for every new patient who comes to the Institute, we do a detailed intake, and I do it myself. So again, I get a sense of where that patient has been, what their expectations are. I don't necessarily offer clinical trials to every patient, but obviously in running a clinical trial center, we give many patients that option. And unless we can enroll patients in our clinical trials, it will be absolutely impossible to move our science forward. So this is an invaluable component of what we all do as clinician scientists.
All right, thank you. Any comments, Dr. Harris? Yeah, so the only reason we've been able to even start clinical trials and move trials forward, and as well as our understanding of vitiligo, we talk about interferon gamma and JAK signaling and IL-15. The only reason that we've been able to do that is because of all my own patients actually who volunteered to participate and give us samples of their skin and their blood and to analyze and learn about. Really, all those discoveries are because they helped out. And that wasn't even a clinical trial. I couldn't even tell them they might get better. They were simply giving us some skin for one time. And it wasn't going to help them at all other than learning about vitiligo. And it worked. We've had hundreds of patients who have allowed us to do that. So I have to thank them if anybody's on here and has done that with us and for us. Beyond that, though, same thing as Pearl said about clinical trials. If people don't enroll, we'll never learn. But I agree also that it's not for everybody. So, should people enroll in clinical trials? We're all kind of biased because we need that in order to move this forward. But it's not for everybody. If you enter a clinical trial, usually there's a chance you're going to get a placebo. That's the best way to do a clinical trial. So it's possible you'll go without a treatment. You'll put a cream on, or you'll take a pill, and it's not the actual treatment. So we can compare it. A lot of clinical trials let you get the drug eventually for enrolling. It can be a long process. We had a patient who came down from Montreal, actually. He flew in from Montreal every month to be in a clinical trial. He was rewarded. So within a couple months, his face was 100% repigmented. And so he was really happy. But we've also had people who have not gotten better. And it might be because they were on placebo, or it might be because the drug didn't work. And we're doing the best we can to try to pick the best things for our patients to try. But they don't always work. And so you have to have that in mind and be willing and able. I always tell my patients, look, I've got great treatments for you right now. You don't have to get into a trial. We've got good treatments. But we also have the option of maybe a better one, or learning and advancing the science, and you can participate in that. So it's something you have to think about and talk about with your board certified dermatologist, and decide if that's the right thing for you.
Great. Well, I just want to make a few comments on clinical trials. First of all, I want you to know that we actually are the ones who consult with these companies for clinical trials. And we are physicians first, dedicated to our parents first and foremost, and then researchers after that. And so when we talk to companies, the companies as well as ourselves are really thinking of your best interest. We want to make sure the drug is as safe as possible. We want to make sure that the medication is being monitored carefully. It has a good chance of working. I'm not going to put my patients on something that I don't think has a good chance of working. So fortunately, the trials that are being done in vitiligo are for medications that really do show a good chance of working. And that's something that we insist on when we're talking to pharmaceutical companies. This is not a capricious type of process. This is a process that's very well described, and it's an iterative process in which we make sure that the study is done correctly. Now, just like John says, it's not for everyone. There are some people who are very comfortable with risk. Oh, I've got a 1 out of 5 chance of getting placebo. Well, I got a 4 out of 5 chance of getting something good, so I'm in. Other people say, what? 20% chance of placebo? No, I just got vitiligo and I'd like to try the tried and true treatments before I even consider a trial, and that's fine. We want to make sure you know that you're going to be taken care of whether you join the trial or not, because we're physicians first and investigators second. And so that's why we say it's not for everybody. It doesn't necessarily have to do with the fact that the trial is bad. It has to do with the fact that every person has a different degree of risk and comfort with being on a trial. And these medications aren't something that someone just kind of took off a shelf and are just randomly trying on vitiligo patients. They've already been used in other diseases like hidradenitis suppurativa and celiac disease, and we already know some of their toxicities so that we can use something that's safe for you. So I would recommend that you consider a trial, especially if you've already tried 1 or 2 treatments and either you can't go in for phototherapy, or you're having trouble affording it, or you feel like you've relapsed and you'd like to try something different, then I would recommend that you consider that. All right, now we're going to go on to some of our chat questions that we've had in the chat. We've talked about, there was one question that says, what is the effectiveness of Xeljanz, which is tofacitinib? And tofacitinib seems to work well for vitiligo, but it's very expensive, in the thousands of dollars per month for 60 pills. And when you stop it, your vitiligo can come back. And there's also some blood tests that you have to get to make sure it's not toxic to you. So Xeljanz oral is something that can be used, but it's really not practical in our day-to-day treatment here in the United States. Topical Xeljanz, which is topical tofacitinib, is being used by some physicians, compounded from a compounding pharmacy, and it seems to have some effect, but it's not approved by the FDA, and hopefully in a couple of years we'll have that approved by the FDA. And the second question I'll answer before I turn it over to the panel is advice on home light therapy treatments. I don't think that home light therapy should be bought by somebody without the instructions and guidance of a doctor, of a dermatologist. You are just asking for a disaster. You're asking for potential burns. You're asking for lack of efficacy. You're asking for confusion on what's jewels and, you know, how do I do it? What's my position, etc. So with prescriptions that can be obtained from some doctor online. I think it's best if you go to a dermatologist and get the home phototherapy from a dermatologist. They are safe. They can be used effectively at home, and insurance companies sometimes, not always, will pay for it. But it's usually less expensive, much less expensive than the amount the insurance pays the doctor for doing it in his office. And so hopefully over time, we'll be able to get more approval for home phototherapy for patients to get the treatment at home safely. And I leave it open to Dr. Grimes.
Yeah. You know, we have been working with patients using home phototherapy devices for at least 20 plus years. And I feel strongly that they do have a place in our therapeutic armamentarium for vitiligo. So I am an advocate. However, my greatest frustration is when patients don't follow the protocol and they don't work with the physician in ordering these units and they don't use them appropriately. And when you don't have guidance and you don't understand how they are to be used, you are not going to achieve the desired outcomes. So I agree with you 100%. The purpose of these units is to ease the comfort for you so that you don't have to come in and see a physician, but it's still a partnership between you and your hopefully knowledgeable dermatologist regarding how they should be used.
Right.
Amit, I'll just add into what Pearl said, and I completely agree. I think home phototherapy certainly has a value. I'll tell you, it has had an incredible amount of value in my practice during this COVID-19 pandemic, when we were not able to have patients come in for phototherapy. And, you know, patients were devastated that they couldn't come in for phototherapy. Imagine someone has vitiligo, they're coming into my office for treatment, seeing results, and then being told you have to shelter in place because of a pandemic, rightfully so. But now patients were petrified that they were going to go back in reverse and their treatment was not going to continue to improve. This was a huge issue. And home phototherapy was actually, interestingly enough, one treatment that I could do over telemedicine virtual visits, literally looking at the device in my patients' homes, helping them get the dosing right, helping them guide through it. So I think home phototherapy certainly has a role, and it opened my eyes this year more than ever. So that's my first comment. My second comment is, since we're talking about phototherapy, I saw several questions come up about what your skin should look like in phototherapy. Yes, sometimes the surrounding skin around the patch of vitiligo may get darker. That's because narrowband UVB or full body phototherapy and even the targeted phototherapy, which is delivered via a laser, can stimulate that pigment to come back, not just in the vitiligo areas, but also on the edges. And that, in my experience, does tend to even out over time, but that is something you need to tell your patients. Yes, I'm going to try to make your white patch into your normal skin color, but you may get a little darker on the edges, and that comes with the territory. So you need to counsel, and I let my patients know about that. And the other thing I'll mention is I get a lot of referrals here in my region, and Dr. Pandya got many of these same referrals and knows exactly what I'm talking about, from patients who have been getting phototherapy at doctors' offices, but honestly weren't getting the right dose or weren't getting the right amount of phototherapy. And so I tell my patients, you don't want your skin to burn and blister and look sunburn. But at the end of a treatment, when you come back to your next treatment, I hope you will tell me that your skin was pink. It didn't hurt and itch, but you saw color. because if you don't see any of that pink, light redness, and actually I always coined this from Dr. Pandya because he gets the credit for this, but the prom flower that everyone used to take to their prom, the carnation flower, is the color. And that's, Amit would always share that with his patients. And I give him credit for that because I tell my patients that underdosing in phototherapy is as much of a disservice, in my opinion, as overdosing. So it's a happy medium, and talk to your specialist about making sure you're on the right track, either home phototherapy or in office.
Okay, thank you. We've got 5 minutes left and the questions are amazing. There are so many questions here. I'm going to just highlight a few of them. One person said, I'm currently on a Pfizer oral trial. It is working amazingly. This is the oral JAK inhibitor, which is already enrolled its phase 2 study. And if it works, the phase 3 study will likely go on next year. I just read about ginkgo biloba. Is this good? There is one study in which they use ginkgo biloba, I think 3 pills a day compared to control. And it seemed like that helped patients with slowly advancing vitiligo. And it is safe. Also, alpha lipoic acid has been used along with vitamin C and vitamin E in another study, and it showed definite improvement compared to a placebo. And so there's just so many questions here that we can answer. But I do want to ask one question to the panel, where someone said that their vitiligo was stable for 6 years, but now it's really taken off. And that happens in our offices all the time. Doctor, I just had vitiligo on my elbows and knees and a little bit on my hand, but this year it's coming all over my face, and it's really taking off. So I'd like to ask, let's start with Dr. Harris. What and how do you explain that? This is what patients live in fear of, is next week's lesion and getting worse, in the future. Why does that happen? Why do they just are stable for many years and all of a sudden it takes off like that?
We don't know, and it's unpredictable. I've seen it too. I had a patient come in, and he'd been stable for 20 years, and then all of a sudden it started taking, and he'd never used a treatment because it was pretty limited. It didn't grow, so he just learned to live with it. And then all of a sudden it started taking off and spreading. And we put him on narrowband UVB phototherapy, and 6 months later, I couldn't find vitiligo anymore. He was one of the best responders I'd seen, and he'd had it for 20 years. And then it just became active. So the good news is the treatments still work, even though this can happen. There are triggering events, some chemicals that can trigger vitiligo. We don't know too many of them, and most of them aren't on the market anymore. So you're probably not getting in contact with the strongest ones. But there are some things that can do it, and so it might be something you came into contact with, but most likely it's just unknown.
Okay, yeah, Dr. Grimes, we got 1 minute left.
Okay, I'll go fast, really fast.
Okay.
If I have a patient who is spreading, I'll go through their history. If they haven't had labs in a while, I'll check their labs, thyroids. And obviously we do want to stabilize them. I know you like oral mini pulse dosing. I think we all use it. I also use intramuscular Kenalog. I use oral steroids in my pediatric population. So we really do want to work to stabilize as we repigment. And back to what John said, we can also stabilize with a very effective narrowband UVB regimen as well.
Thank you. Well, I want to thank MyVitiligoTeam. I want to thank the Global Vitiligo Foundation. I would ask everybody to support these organizations because they are working for you, the patient with vitiligo. I want to thank my esteemed panelists for joining us on this call, and I hope we can do this in the future. I apologize to everybody whose questions we were not able to answer. I hope that somehow we can answer some of these questions over time. But our time is up at this point, and so I want to thank everybody for joining, and good evening to you.
Bye, everybody.
Bye, everybody.